So thank you so much. A very good morning to all of you. And Mehta sir had shown such a beautiful technique and an animation of dealing with posterior polar cataracts. So when you're learning phacoemulsification and if you see a hard cataract, you are very scared. But later on, you realize that it is the soft cataracts which create the most trouble. Increasingly, we are seeing a lot of posterior polar cataracts because spurious steroids are being given to patients in some form or the other. And I'm really worried about the amount of havoc that the steroid, which had to be given to save the patient's life during COVID, is going to cause to the patient's cataracts or the eyes, regards with glaucoma and cataract in the future. Now, as KK Mehta sir has already told us that these are the cataracts which invite capsular rupture. They look easy, but they're very difficult. There may be a frank defect or just an attenuation which can be seen. Now, as you can see over here, what are the signs of caution? Peripheral thin opacification and mottling all over suggest a intact capsule. Thick opacification in the periphery of the central plaque suggests a dehiscence. So all these points help you. So a very careful slit lamp examination of the patient is very necessary when dealing with these type of cataracts, because before you start the surgery, you need to know the status of the posterior capsule, because you need to deal with it by having a vitrectomy setup. These patients are very young. Patient counseling is very important. You have to change your operative technique, and a posterior segment instrumentation readiness is extremely important. So these are the important tips, because the patient is so young. The patient, because of the posterior polar cataract, may have very good vision, and the expectations of these patients are very high post-operatively also. It's because it's not like a mature cataract whether the patient is hand movements and would be happy with anything. These patients have very good vision unless in bright light, and their expectations are very high. A proper slit lamp examination, pre-operative evaluation, change of operative technique is extremely important. So what is the incidence of posterior capsular rupture? This is what is being given in the scientific journals, that, but without the percentage, I must tell you that the incidence of posterior capsular rupture in the posterior polar cataracts is much higher than in other cataracts which go uneventful, and hence one must be cautious. What are the difficulties in doing phacoemulsification? It's a very soft cataract. So you cannot chop, because if you try to chop, you will go through the substance of the cataract and the posterior capsule. And the posterior capsule itself is weak. So your fluidics are very important. So what is the technique that you can choose? A small rhexis, because in case you have a PC tear and if you want to put in the IOL in the sulcus on the anterior surface of the capsule, then a smaller rhexis will be of greater help. Hydrodissection and hydromaneuvers can be completely avoided. So what you can do is only hydro delamination, because hydrodissection is fluid between the capsule and the lens, which may go and a small defect may be enlarged. So no hydrodissection or hydro-free phaco, and only the hydro delamination is used, which is very important. And since the cataract is very soft, but in order not to disturb the posterior capsule, your parameters have to be low vacuum, low inflow, and low aspiration. So, and dry aspiration of cortex or epinucleus, or very careful aspiration, because you may get away with doing a very good phaco, but it is during the cortex aspiration, if there is some adherence of the cortex to a plaque on the PC, which may cause a PC tear. So that is very important. So this is a soft cataract, as we will be seeing. This is a video of a soft cataract that we will be seeing. So this is what we will be following, a no chop aspiration technique. So this is the first case, as we can see. So as you can see over here, a good glow, a classical posterior polar cataract, hydro delamination, that means you are going into the substance of the lens and injecting the fluid, the golden ring, multiple points of hydro, and now the phaco, it's impossible to divide or chop, and hence, aspirating, as you can see, the salute technique of Dr. K.K. Mehta sir, of flipping the nucleus and aspirating the nucleus as a whole, is a mainstay of this technique. This is the first technique where stop and chop is not possible at all. Again, the second case where you can see a posterior polar cataract, the golden ring, and now you see the cataract is so soft. The carousal technique or the bowl technique, where whatever you try to do causes a crater. So what you need to do is you have to rotate the lens and get an edge of the lens in order to aspirate the cataract completely. So as you can see that what is written is what we are seeing, that this is a saucering effect. So rotating the lens and then getting one edge of the lens and treating the whole lens as a piece of nucleus is what you can do. Because if you try to do anything, that whole cavity gets excavated. So removing this as a whole is the technique which works. Different cataracts behave differently, and the technique which works in your hand is very, very important. So this is the third patient where you are doing multiplanar. So small amount of fluid, different, because large amount of fluid at one site at one time may be very difficult. As you can see, the cataract is already saluting, and rotating the cataract and removing it is extremely important, as you can see over here, to remove the whole cortex. There is a huge epinucleus which is left behind. In these type of soft cataracts, only aspiration is used here. You don't need to use phaco at all because the cataract is so soft. And this epinuclear buttress is the main safety factor which keeps your PC away from this, and which helps you. But this has to be aspirated very, very carefully, because if you don't do that, a blunt chopper is used because otherwise you may cause a PC tear. This is the fourth case where, so this is soft cataracts, look easy, but they are more difficult. We must be prepared for a secondary IOL. There are multiple techniques. The thing which works in your hands best is what is important for you and for the patient. Thank you very much.